Now, good afternoon. I hope all of you had lunch. Good. So the judges are here to judge your work, and they are going to be on the content, on the presentation, on the quality, and overall impact. So it could be like if it is something which is innovative, probably it will get more marks. How many marks you're going to allot is between us. But we start with the first video, which is a novel all-nasal approach for lens-sparing vitrectomy in stage 4B retinopathy of prematurity. I have Dr. Simar Rajan Singh. Simar Rajan Singh, you tell me, I'll start your time. Timers, you should put it. 8th minute, switch it off. Okay? So the presentation will switch off at 8th minute.
285.
Yeah, it's here, whatever. Out of
Audio,
40.
Novel all-nasal approach for lens-sparing vitrectomy in stage 4B retinopathy of prematurity. The producers have no financial interest in the subject matter of this film. ROP is a disease which is inherently more severe in the temporal half. A large number of stage 4B ROP cases have extensive detachment of the temporal retina, which in some cases approaches the retrolental space. A conventional approach to vitrectomy requires 2 of the 3 sclerotomies to be placed in the temporal half. In cases with stage 4B ROP, this endangers hitting the lifted temporal retina, and a more horizontal approach would necessitate a lensectomy, thereby taking away the advantages of lens-sparing vitrectomy. We propose a novel all-nasal approach with the surgeon seated opposite to the eye being operated. The infusion cannula is placed centrally at the 3 or 9 o'clock position for the right and left eye respectively. The other 2 ports for the vitrector and endoilluminator are placed on both sides of this port. The rest of the principles of lens-sparing vitrectomy remain the same. We now demonstrate the real-life use of this approach in cases with stage 4B ROP. This case was a 3-month-old child with stage 4 ROP in the left eye with progression despite confluent laser treatment. An all-nasal approach was attempted with the surgeon sitting on the right side. The first trocar is inserted at the 9 o'clock position. This cannula is used for the infusion. As the surgeon's hand rarely crossed during surgery, a centrally placed infusion does not interfere with the active vitrectomy ports. Another advantage of the central placement of the infusion is the support provided to it by the shallow nasal bridge of the infant. This prevents the cannula from flipping over and hitting the crystalline lens. The arrangement of the cannulas can be seen here from the surgeon's perspective, with the position of the surgeon while operating from over the other eye. Intraoperative OCT documents the steep detachment of the temporal retina, which would have necessitated a lensectomy if approached from the standard superior side. Vitrectomy is started with removal of the traction between the lens and the ridge, followed by ridge to periphery dissection. All the quadrants can be approached with ease. The ridge-to-ridge proliferation is then carefully segmented with cauterization of the new vessels bridging between the superior and the inferior arcades. An OCT after the release of the traction demonstrates a substantial reattachment of the temporal retina. The case is closed after a partial fluid air exchange and suturing the sclerotomy ports. The patient had a good anatomical outcome at 3 months after the procedure. The second case was a 4-month-old infant with extensive retrolental fibrosis on the temporal side with detachment extending into the posterior pole. The vitreous cavity was approached via the all-nasal approach. The pocket of fluid can be clearly visualized at the posterior pole at the start of the procedure. After clearing the core vitreous, Tramsin alone was injected to stain the posterior hyaloid. Posterior vitreous detachment was induced at the disc and extended up to the ridge. Further removal, especially on the temporal side, risked creating an iatrogenic break due to the densely adherent hyaloid and lifted retina. The attachment of the posterior pole compared to the preoperative image could be visualized on table, and the same was confirmed with microscope integrated intraoperative OCT. The case had a good outcome with attached posterior pole 6 months after the procedure. The third case was a relatively older infant who presented to us at 6 months of age with a falciform pole involving the fovea. All sclerotomies were placed on the nasal side. The nasal bridge supporting the centrally placed infusion cannula can be visualized here. The extensive detachment of the temporal retina approaching in the retrolental space is evident. A core vitrectomy was performed. In an attempt to open up the falciform fold, triamcinolone acetonide assisted posterior hyaloid removal was done. All maneuvers could be done with ease through this approach, right up to the temporal periphery. Intraoperative OCT demonstrates the release of the pole at the end of the procedure. Postoperatively, there was progressive opening of the falciform fold with reattachment of the posterior pole over 6 months. In conclusion, this novel all-nasal approach for lens-sparing vitrectomy with central placement of the infusion cannula appears safe and effective in the surgical management of select cases of stage 4B retinopathy of prematurity. With proper case selection, iatrogenic retinal injury and lensectomy can be avoided in many of these eyes. Thank you.
Thank you so much. Is there any questions from the judges?
So did you use a pediatric set for this? I mean the
No,
introcar
sir.
cannula system?
No,
and
sir. As it is only in India, currently Alcon provides the shorter instruments, but they come with no trocars, no cannulas. I'm sorry. So they say that you'd make a direct entry in the sclera and go through that for the pediatric cases. But we believe in using the advantage of
Retinal surgeries.
the cannulas.
We have no-
So that is why we prefer a partial entry at the start and then pushing the cannula in and taking the trocar out so that the lifted retina does not get injured.
any problem in giving GA because you have the intubation, so you're sitting on the
We
nasal.
did not have any issues with that because all these babies were intubated with a tube, no laryngeal mask airways, and the orientation was always, we did an pre-operative examination under anesthesia, saw the areas which were free of any anterior traction, and then decided on the approach if the nasal side was completely free of any traction. And the GA arrangements were made accordingly before cleaning and draping the baby.
In your last series, how many of your patients whom you planned lens sparing you had accidentally lens in
So
hand?
for now we have a series of 8 cases with more than
Okay.
6 months of follow-up.
None case required lensectomy.
One case
case,
required
okay.
lensectomy.
So that's about nearly 10, 10% of the patient do require converting into a
Yes,
lens.
sir. But
and all.
other series otherwise
you.
which report results of stage 4B with
4RB.
peripheral traction report up to 30 to 60% of rate of lensectomy if there is presence of peripheral traction.
And one last question is, all these falciform folds, how much is vitreous traction and how much is subretinal traction? There is a shortening or there is a
So
that called without releasing, how does the retina go back?
So primarily we feel this is not subretinal because there is no
Okay.
reg component to it. It is a tractional detachment because of fibrosis and the vitreopathy.
Okay.
So nicely clearing that up and releasing the fold mostly helps in these
Fine.
cases.
Thank you so much. It was wonderful.
sir.